we have next is a 36 female who had come with bleeding PR multiple times, and there is a ulcerated submucosal mass in the upper rectum. The biopsy showed a leiomyoma, and these are the EUS images of the same area. The plan is for an endoscopic resection. So over to you, sir, in OT4.
So the slogan for this meeting are the 3 I's. It is intervention, insight, innovation, and maybe I can add a 4th I, individualize. You need to individualize what we do for each patient, for each case. Each patient is unique. So this patient has a leiomyoma. We already know that from the biopsy, so that's important. We know that this is not really a precancerous lesion, but as you can see on the endoscopic view, it's fairly sizable. I'm going to pull back here. I'm going into the sigmoid now, and there's the lesion. And you can see that on the surface, apparently there was some ulceration, so these can bleed. So the risk to the patient is bleeding, but obviously there's also some lumen obstruction. So I think treatment is warranted. This is theoretically something that does not need to be removed because it's not pre-malignant. But I think we can make an argument for removing it in this patient based on the larger size and the fact that there was previous ulceration. So we're always weighing risk and benefit in everything that we do in medicine. And it's important that we always do this when we consider the different options for endoscopic treatment. Of course, everyone is infatuated with ESD and resections, third space, but I'm not sure that ESD is really the best option for this patient for something that's in fact not even pre-malignant. So what I'd like to show you today in the spirit of innovation, the I, is a different way that you can remove this using a double channel scope, deploying 2 instruments through each of the channels. And for 2 instruments, I need 2 assistants. So I have Manowich, is that right? Manowich? Okay. And Ashwani to my right, very important because you can see they both have a device in each of their hands, and I've inserted these through the left and the right working channels. I'm going to have one assistant just hold my scope as well, so I need even a third person to just make sure that my scope doesn't slip back. It's okay right now. But here now, through the left channel, this is the Ovesco 3-prong grasper. You could use anything, but you need something that is not just going to capture the mucosa, because this is a subepithelial lesion. So if you use a forceps or so, then it's going to just tent the mucosa away. You're not going to get the underlying tumor, the leiomyoma. In the right channel now, and again in the spirit of innovation, is something I devised. So it's a loop, but the limitation of the conventional loop that we all have used, which is the Olympus loop, is that it's very, very floppy. It's probably not that much of an issue for this case today, but it's an opportunity for me to show you how one can make a loop stiffer. The loop is the same, but it's mounted on a snare. So by mounting it on the snare keeps the loop stiff and rigid when we deploy it. So essentially, it's like putting a snare around the lesion. So our first step is going to be to advance the snare with the loop mounted on it out of the catheter. So you see the catheter, you can see the tip. And what Ashwani is doing now is he's simply pulling this sheath backwards, which advances now the snare forward. So keep pulling it back, Ashwani, keep pulling. So you can see this loop is mounted on a snare. So now I'm going to push and I need someone to hold my scope. I'm going to push the 3-prong grasper through the loop, right? Like this. And I'm going to now pull the loop back like this. And I'm going to get a little bit more distance away, maybe rotate a little bit to get into a better position. Now you want to make sure that your that your loop is recessed back far enough. Let's do this again because I just slipped out, but I'm going to push it forward like this, get a little bit further out so I can pull the loop backwards. All right, like this. So as mentioned, I don't think the stiffness is that critical in a case like this, but it is a case where you have a lesion that is very much flatter, has a broader base, and then you really need a loop that pushes flush up against the bow wall. So now I'm going to move my three-prong grasper over a little bit, and as soon as I have a good view, it's just a very difficult position because we're in the sigmoid. Now, remember, even if this were a GIST lesion, our options to remove something originating from the muscularis propria are very limited. We can do a stir, we can do ESD, but you have a high risk of perforation. So you need to be prepared to close a perforation. We want to avoid that. Go ahead and deploy the three-prong grasper. So now Manowich is just push it out. You see one of the prongs kind of came out a little bit. And that's okay. Now I'm going to push this second one forward. This is the loop. And I'm going to pull this in forcefully. So I'm getting the loop all the way out like this, putting it flush up against, and I'm pulling back like this. And you can pull back pretty forcefully so that I'm really pulling, if you will, the attachment to the MP. I'm involuting the wall. It's blind, but now I'm going to have, you're going to now close by advancing this forward like this. All right. And when it's tight, so advance it all the way forward. Is it tight? You feel it tight? It's just a chance for me to, okay, is it tight now? Do you feel that it's advanced all the way? All right. Now you're going to close the loop here. So this is the thumb ring. You're going to pull the thumb ring. Yeah, close all the way. Close it all the way until it's, so you don't feel it go forward anymore. So all the way. All right. And when it's nice and tight, you're going to pull this back again. All right. Yeah. And this is then going to, when you pull that back and now you push the thumb ring forward. All right. That releases then, and you can release the Ovesco clamp now, please. Yeah, just pull it back. Yeah. It just will come out. I'm just using this Ovesco three-prong grasper for retraction. It's a retractor. Did you close it? Okay, there. You need to close it. There you go. Okay. So now, and you advance. Yeah, release now the loop, please. All right. So he's just pushing forward to release the loop. Okay. And let's see if it released. Just have to, it's a little bit more constrained, the space here. Okay, close now the snare, please. The other way, push this one forward, the snare. Yeah. So you have to realize the snare in a constrained space makes it a little bit more confusing, perhaps. Now the snare is out and the loop is out. I'm just going to push this all the way.
So would elevation prior to
Here's the end. All right. So now look at this. It's already started to turn violaceous. And I'm going to put a second loop below the first loop.
Dr. Mueller, I have a quick question. So you have described a technique called Arlep technique for a similar lesion like this in the stomach.
So Professor Binmoeller, before
Yes.
you go to the next step, we are going to Professor Dr. D.N. Reddy, sir. He has
Okay.
completed the bile duct.
I just want to show you here how well this worked, right? There's the slip knot. Yes. And that slip knot really holds its position very nicely at the attachment. And when you use the standard loop, which I'm going to show you right now, the problem, can I have that loop, please? So this is now the standard Olympus loop. This is also 30 millimeters in diameter. So
sir, the first,
same as the other one. So you see here, I'm going to advance this out. Open the loop, please. So this is the Olympus loop. The problem, though, is it's very floppy. Is it already open? So you see how it's already flopping down? And one of the problems that we encounter, open it all the way, please. Open the loop, please, all the way. Is that when you start to close the loop, the tip flips up. And then it's not actually going to stay flush up against the wall. All right, so this is a grasper, and what I'm going to do now is just grasp the tip of this. So open the grasper, please. Close the grasper. Good. And I'm just going to pull this into this loop here, right? So I'm going to loop the loop. So if you can hold the scope like this.
Dr.
You
Mueller?
can see how vascular this is. So what I'm doing now is I am pulling. And this is the problem with this loop. See how floppy it is? So it's kind of hard for me. I'm trying to get it to go to the base like this. Hold it right here. Going to pull this back a little bit more. See how this is giving me traction, right? Now I'm going to close this loop below. So the blue loop is closing below the green loop. Okay? So now start to close the Olympus loop, the blue loop, and just start closing it. Now what often happens is it flips up and it doesn't close well. See, it didn't work very well. So that's the problem, is that it flips and then it just doesn't give a good, stay flush up against the wall. Just go ahead and deploy it. Did you deploy?
Can you hear us?
Are you deploying? So you should see the cable advance forward when there's the cable coming, right?
Dr. Rajesh,
There it is. Okay.
this is
Push
from
it all the way forward and then pull.
not audible.
Yeah. So you see what happened here is it didn't work the way I wanted it to, which is that blue loop needed to be over the lesion. And it's basically just looping the base. So that's not accomplishing anything. All right. So release it, please. So I'm going to do it one more time. It's not a problem. Did you release the Olympus loop? I'm having trouble pulling it off. Yeah, this is the other problem that we sometimes encounter with this loop is it's hard. There it comes. Okay.
Rajesh, are we audible are we
I'm
audible?
going to put one more on there. And so now the debate is, or the discussion could be, do we need to actually resect this, or can we just let it slough off? Right? So this is called loop and let go because we know it's a leiomyoma. Now, if it were a GIST lesion, what I do is I incise it and in a cruciate manner, make 2 incisions, and then I just let it enucleate. Because now you opened up the mucosa and like a flower, and then you let the lesion just spontaneously enucleate on its own. And I do get biopsies with a large jumbo biopsy forceps so that we can calculate the mitotic index if it's a GIST. But what you've done is you've inverted the wall so that you're getting a full thickness ligation. So it's just maybe in some ways a more clever way of treating this without any risk of perforation.
Thank you, Professor Binmoeller.
Are we audible?
Yeah, can we go to the room? Professor Binmoeller,
Yes, of course.
I think you have done your job completely.
Thank you. Thank
Thank
you.
you,
Just going to
and
put one
I
more
will-
fun and then we're done.
Sir, I think audience has one question.
Yeah,
I see. This is.
Please go ahead.
Release this, please. Yeah, thank you.
Dr. Mueller, can you hear us?
Give me a new loop.
Yes, Chairperson, we can hear you. Please go ahead. Ask
Yes.
your question, please.
So like this is a procedure which you have described called as Arler procedure. The previous cases were in the stomach, but this is for the first time we are seeing a case in the rectal area. So this case like this can be done even in rectum.
Yes, so actually, this is, so the reason why I think in the rectum, it's all the question of anatomy. So in the rectum, especially if you're below the peritoneal reflection, then I think actually to do full thickness resection is very safe. And I do that commonly where I've already looked at the perirectal fat and it really has no consequence because you're not in the peritoneum. In the stomach, you're very safe because you have a very thick wall. But in the sigmoid and the colon, it's very different. And the wall is very thin. So it's really hard to do a stir procedure in the colon. So then you're really looking at just doing ESD otherwise. This would be for if you wanted to resect the lesion completely in the index session. And you have to basically expect that you'll have perforation and you're going to need to close that hole very fast. And that can have disastrous consequences in the colon.
Thank you, Professor Binmoeller. We